welcome to ICU Primary Prepcast.
Hi, I'm Maddy.
Hi, I'm Swapnil, and today we are going to discuss about endocrine pharmacology. This podcast will cover oral hypoglycemic agent, insulin, and thyroid pharmacology. Are you ready?
Yes.
Let's start with the insulin. We commonly use insulin in ICU. So, can you please describe the pharmacology of naturally occurring human insulin?
So insulin is a naturally occurring hormone which is composed of two amino acid chains, A and B. These are connected by disulfide linkages and formed in the beta cells of the pancreas by the removal of a connecting C peptide from proinsulin. Increased plasma glucose results in glucose influx via glucose transporters, especially GLUT2. The glucose is then phosphorylated to glucose 6-phosphate by glucokinase, which is the rate-limiting step. This is then metabolized to pyruvate, which enters the mitochondria and is metabolized to CO2 and water by the citric acid cycle, with the formation of ATP by oxidative phosphorylation. This inhibits ATP-sensitive potassium channels, resulting in membrane depolarization and opening of voltage-gated calcium channels. The subsequent influx of calcium stimulates fusion of insulin-containing vesicles with cell membranes, and thus insulin secretion via exocytosis. The insulin binds to a specific insulin receptor on the cell membrane, which consists of a large transmembrane glycoprotein complex made up of 2 alpha extracellular binding sites and 2 beta intracellular transmembrane proteins. Insulin binds to the alpha subunits, which autophosphorylates tyrosine kinase residues in the beta subunits, which then phosphorylates other intracellular enzymes, including insulin receptor substrates. In terms of the pharmacokinetics, human insulin is almost entirely bound in the plasma and does not cross the blood-brain barrier or the placenta. It is degraded by insulinases, mainly in the liver, but also to some extent in the kidneys and muscle tissue. The plasma half-life of human insulin is approximately 6 minutes, and it is cleared from the circulation within 10 to 15 minutes. In terms of the pharmacodynamics, insulin affects carbohydrate, protein, and fat metabolism, and one of the most important roles of insulin is to control which types of food are used for energy. So thinking about the effects of insulin on carbohydrate metabolism, it causes an increased uptake of glucose by cell membranes, especially in muscle and liver cells and adipose tissue, through the glucose transporter GLUT4. The glucose enters the cell and is then phosphorylated, becoming a substrate for subsequent metabolic functions. Increased storage of glycogen in the liver is also as a result of increased insulin. The insulin inactivates liver phosphorylase, which is the enzyme causing liver glycogen to be broken down into glucose, and it also inactivates glucose 6-phosphatase, which is the enzyme that converts glucose 6-phosphate to glucose. Insulin increases the uptake of glucose by liver cells through increasing the activity of glucokinase, which is the enzyme that causes initial phosphorylation of glucose intracellularly, and thus temporarily traps glucose in liver cells. Insulin also increases the activity of enzymes which promote glycogen synthesis, especially glycogen synthase, and it inhibits gluconeogenesis. Insulin has little effect on uptake or use of glucose in the brain, as these cells are already permeable to glucose without insulin. The effects of insulin on fat metabolism are mainly to promote fat synthesis and storage. It does this by increasing the utilization of glucose by most tissues in the body, which decreases the utilization of fat. It also promotes fatty acid synthesis by increasing transport of glucose into hepatic cells. After the liver glycogen reaches 5 to 6%, further glycogen synthesis is inhibited, and additional glucose enters the glycolytic pathway to form acetyl-CoA, which is a substrate for fatty acids. These are then packaged as triglycerides in VLDLs and transported to adipose tissue. Insulin also activates lipoprotein lipase in the capillary walls of adipose tissue, which splits the triglycerides back into fatty acids so that they can be absorbed into the adipose cells and converted back into triglycerides. It also inhibits the action of hormone-sensitive lipase, which is the enzyme that causes hydrolysis of triglycerides in adipose tissue. And finally, it promotes glucose transport through the cell membrane into adipose tissue. It largely forms alpha-glycerol phosphate, which then combines with fatty acids to form triglycerides, which is then stored in adipose tissue. Finally, the effect of insulin on protein metabolism and growth is to promote protein synthesis and storage. Insulin does this by increasing the cell membrane permeability to many amino acids, potassium and phosphate, which causes increased transport into the cell. It also increases the translation of messenger RNA, thus forming new proteins, inhibits the catabolism of proteins, and depresses the rate of gluconeogenesis in the liver. The substrate most used for synthesis of glucose are amino acids. Thus, insulin helps to conserve protein stores in the body. It also interacts synergistically with growth hormone to promote growth.
That's a very comprehensive answer. Now let's move on to some of the commercially available insulin preparations. Can you name them and also tell us how do they differ in their time course of action?
So commercially available insulin is available in a number of different formulations, which are generally classified according to their duration of action into rapid onset, short, intermediate, and long-acting, or a mixed preparation. They are manufactured using E. coli and recombinant DNA technology. Insulin is usually given subcutaneously, but the short-acting formulations can also be given intravenously. Examples of rapid onset insulin include insulin Lispro or Humalog, Aspart or Novorapid, and Glucine or Apidra. The onset of these rapid onset insulin is within about 15 minutes, with a peak of 1 hour and a duration of between 3 to 5 hours. Short-acting insulin include neutral, such as ActRapid. The onset of this is within 30 minutes, a peak of 2 to 4 hours, and the duration is 6 to 8 hours. Intermediate acting insulin includes isophane, such as Protophane or Humulin NPH. The onset of intermediate insulin is within 1 to 2 hours, with a peak of 4 to 12 hours and a duration of 16 to 24 hours. And then there is long-acting insulin, such as Detamir or Levemir, and Glargine or Lantus. The onset of Levemir is within 3 to 4 hours. It has a peak of 9 hours and a duration of 12 to 20 hours. Lantus has an onset of 1 to 2 hours, no real peak effect, and a duration of 24 hours. Finally, there are mixed preparation insulins, which are pre-mixed combinations of either a rapid or a short-acting insulin mixed with an intermediate-acting insulin. For example, 30/70 of insulin means there's 30% short-acting and 70% intermediate-acting insulin.
Okay, now can you list the classes of oral hypoglycemic drugs and their mechanism of action? And can you also list some of the side effects?
There are several classes of oral hypoglycemic drugs available today. These include biguanides, sulfonylureas, thiazolidinediones, dipeptidyl peptidase 4 inhibitors, sodium glucose cotransporter 2 inhibitors, alpha glucosidase inhibitors, meglitinides, and glucagon-like polypeptide 1 receptor agonists. Biguanides are probably one of the most common oral hypoglycemic agents used, and these are things like metformin. They work by inhibiting hepatic gluconeogenesis, decreasing the intestinal absorption of glucose, and increasing insulin sensitivity by increasing peripheral glucose uptake and utilization. Side effects include nausea, epigastric discomfort, and lactic acidosis. Examples of sulfonylureas include gliclazide. Their mechanism of action is by having a high affinity to the pancreatic beta cell potassium ATP channel receptors, which inhibits the efflux of potassium ions through the channel and result in depolarization. This opens a calcium channel, causing an influx of calcium and the release of insulin. Side effects include hypoglycemia, gastrointestinal disturbances, rash, and weight gain. Thiazolidinediones, such as rosiglitazone, are highly selective agonists at peroxisome proliferator activated receptor gamma in tissues. And these are important for insulin actions such as adipose tissue, skeletal muscle, and the liver. These receptors modulate the expression of genes involved in lipid and glucose metabolism. Production and utilization and agonism results in increased insulin sensitivity, increased glucose uptake and utilization by adipose tissue, and decreased hepatic gluconeogenesis. Side effects include fluid retention, weight gain, macular edema, and loss of bone mineral density. Dipeptidyl peptidase 4 or DPP4 inhibitors include drugs like sitagliptin. These inhibit the activity of the enzyme DPP4, which normally degrades incretins such as GLP-1 and GIP. Consequently, the levels of these incretins increase, and these stimulate postprandial insulin release, slow gastric emptying, and reduces glucagon release. Side effects include upper respiratory tract infections, headaches, pancreatitis, and allergic reactions. Sodium glucose cotransporter 2 inhibitors, such as empagliflozin, are cotransporters which are responsible for glucose reabsorption from the glomerular filtrate in the kidney. Therefore, inhibition results in reduced glucose reabsorption and increased glucose excretion. Side effects include urinary tract infections, dyslipidemia, dehydration, and normoglycemic ketoacidosis. Alpha-glucosidase inhibitors include acarbose. These are competitive inhibitors of intestinal alpha-glucosidases, which normally breaks down dietary complex carbohydrates to monosaccharides, which facilitates intestinal absorption. Inhibition decreases upper intestinal absorption of carbohydrates and delays digestion to the distal small intestine, thereby having an insulin-sparing effect and reducing postprandial hyperglycemia. Side effects are mainly gastrointestinal and include flatulence, abdominal pain, and diarrhea. Meglitinides include drugs such as repaglinide. They have a similar mechanism to sulfonylureas by inhibiting the ATP-dependent potassium channel in pancreatic beta cells, resulting in depolarization, calcium influx, and insulin release. Side effects include hypoglycemia. And finally, glucagon-like polypeptide 1 receptor agonists such as exenatide. GLP-1 agonism results in glucose-mediated insulin secretion, inhibition of postprandial glucagon release, decreased appetite, and decreased gastric emptying. Side effects include nausea, vomiting, diarrhea, and pancreatitis.
Okay, now let's dive into one of the commonly used oral hypoglycemic agent, that is metformin. Can you please outline the pharmacology of metformin?
So metformin's pharmacology can be divided into its pharmaceutics, pharmacokinetics, and pharmacodynamics. Metformin is a biguanide which is available in tablets of immediate or extended release formulations. The pharmacokinetics are subdivided into the absorption and administration, distribution, metabolism, and elimination. Metformin is given orally and has a bioavailability of between 50 to 60%. The presence of food delays and decreases the amount of absorption. The distribution is 654 litres with the volume of distribution, and it's not bound to plasma proteins. Metformin does not undergo metabolism, but is excreted unchanged in the urine with an elimination half-life of 17.5 hours. This is prolonged in patients with renal dysfunction. In terms of its adverse effects, metformin most commonly results in gastrointestinal adverse effects, including anorexia, nausea, vomiting, and diarrhea. It can result in lactic acidosis, and long-term use can reduce vitamin B12 absorption. Unlike other hypoglycemic agents, metformin does not result in hypoglycemia when used alone.
Since we discussed the oral hypoglycemic agents now, let's move on to another endocrine pharmacology. Can you please outline the uses of T3 in intensive care unit?
So T3 or liothyronine is more potent, has a quicker onset and a shorter duration of action when compared to T4. Within the ICU, it is mainly used for two treatment options. One is in the management of severe hypothyroidism, including for mixed edema coma, and secondly, in the management of the brain-dead patient who is a potential organ donor with severe hemodynamic instability.
Can you please outline the treatment of mixed edema coma?
Mixed edema coma is due to severe hypothyroidism and is a medical emergency with a mortality of between 30 and 60%. The hallmarks are altered mental status and hypothermia, but other clinical features include those of hypothyroidism, such as weakness, diastolic hypertension, but often decreased cardiac output, bradycardia, and pleural effusions. It usually occurs in people with long-term undiagnosed or undertreated hypothyroidism who are subjected to an additional stressor, such as in the case of infection or trauma. Treatment consists of thyroid hormone replacement, steroids, supportive measures, and identification and treatment of any precipitating causes. The best type, route, rate, or dose of thyroid hormone to give in this situation has not yet been elucidated. Rapid thyroid hormone replacement can cause arrhythmias and myocardial ischemia, whereas slow replacement subjects patients to ongoing risk from the condition itself. T3, or liothyronine, or T4, levothyronine, or a combination of both can be given. T3 is biologically more active, has a quicker onset of action, and it bypasses the deiodination step from T4 to T3 that is usually impaired in hypothyroidism. The disadvantages of T3 is that it is more expensive, less readily available, and high T3 levels have been associated with increased mortality. T4 is often used instead, as it requires in vivo conversion to T3, thus allowing for a more measured replacement of the thyroid hormones. Due to its unpredictable bioavailability, it is often initially given intravenously at a loading dose of 100 to 500 micrograms, followed by 50 to 100 micrograms daily. This is continued until an improvement in clinical condition is seen, after which the patient can be usually transitioned to oral therapy. Hypoadrenalism often coexists with mixed edema coma. Therefore, steroids are also given to patients until the hypoadrenalism can be excluded. Resuscitation and supportive treatment are crucial in the management of mixed edema coma and include rewarming, ventilatory support, adequate nutrition, thromboembolic prophylaxis, and cautious use of intravenous fluids, keeping in mind that patients are often hyponatremic, and vasopressors if required. Investigation and treatment of potential triggers such as infection should also be completed.
Let's discuss the pharmacology of levothyroxine.
So levothyroxine pharmacology can be divided into the pharmaceutics, pharmacokinetics, and pharmacodynamics. Levothyroxine is the levo isomer of thyroxine, or T4, and is an odorless, tasteless powder. It is available in tablet formulation of 50, 75, 100, or 200 microgram strengths, and as a vial of 200 micrograms for reconstitution intravenously. It is used as thyroid replacement therapy for the treatment of hypothyroidism. The pharmacokinetics can be divided into the administration and absorption, distribution, metabolism, and elimination. In terms of the administration, levothyroxine is most commonly given orally, but can also be given intravenously, such as in the treatment of mixed edema coma. It has a variable absorption rate from the GIT of between 50 to 75%. The presence of food impairs absorption, therefore it is best taken on an empty stomach. It has a slow onset and peak effect occurs between 3 to 4 weeks when given orally. The distribution, levothyroxine undergoes enterohepatic circulation and is 99% protein bound, mainly to thyroxine binding globulin, but to some extent to albumin. These proteins have a higher affinity for T4 compared to T3, which is partially why T4 has a longer half-life and slower clearance when compared to T3. T4 is distributed to most tissues in the body, with the highest concentration in the liver and kidneys. Only the unbound hormone is metabolically active. Levothyroxine does not readily cross the placenta, and it is a category A drug in pregnancy. In terms of the metabolism, over 80% of levothyroxine is metabolized by deiodination to T3 or to reverse T3. These are then further deiodinated to diiodothyroxine. The remainder is metabolized via conjugation with glucuronides and sulfates and excreted into the bile and then undergoing enterohepatic recirculation. The elimination. Levothyroxine has a plasma half-life of 6 to 7 days, which can be prolonged in hypothyroidism to 10 days. It is eliminated in the urine and the feces. Now coming to the pharmacodynamics. Thyroid hormones are thought to exert their effects by activating nuclear receptors that lead to increased formations of RNA and thus increased protein synthesis. Effects include an increased metabolic activity, with the basal metabolic rate increasing by up to 100%, increased protein synthesis and catabolism, increased carbohydrate and fat metabolism, and increased growth and development. Cardiovascular changes include increased inotropy and chronotropy and an increased cardiac output. Respiratory changes include increased respiratory rate. GIT changes include motility, increased appetite, and increased digestive secretions. And central nervous system effects include increased alertness and central stimulation. The adverse effects of levothyroxine are usually as a result of extension of the biological effects of thyroxine and include cardiovascular effects such as tachycardia, arrhythmia, angina, and myocardial ischemia. CNS effects such as irritability, tremor, anxiety, headache, insomnia, and myopathy. GIT effects such as diarrhea, vomiting, and weight loss. Respiratory effects include tachypnea. Thyroid hormones have widespread effects, and many drugs affect and are affected by thyroid function. Consequently, levothyroxine has many drug interactions. This may be due to the effect of drugs on thyroid function, which can be as a result of decreased TSH levels, such as in the case of glucocorticoids, decreased thyroid hormone synthesis, for example, lithium, changes in thyroid binding globulin levels, for example, estrogens, displacement from thyroid binding globulin, for example, frusemide, increased metabolism, such as in the case of carbamazepine, and decreased iodination of T3, such as for beta blockers. Interactions can also be due to thyroxine's effect on other drugs, such as in the case of anticoagulants, levothyroxine can increase the effect of warfarin due to an increased catabolism of vitamin K-dependent factors and displacement of the drug from plasma proteins. Thyroxine can also affect insulin and oral hypoglycemic agents and may increase the required dose of these drugs. The use of digoxin with levothyroxine may reduce the effects of digoxin and need for an increased dose of this drug.
Okay, now I can see that you are very eager to ask me a question. So yeah, go ahead.
Okay. What did the type 2 diabetic say to the type 1 diabetic?
Maddy. No insulin?
You're so juvenile.
Oh, thanks, Maddy. That was a really good joke this time. Okay, so that's the end of our podcast on endocrine pharmacology. Next time, we'll be back with
Antibiotics.
Till then, goodbye and have a nice time.
Thanks for listening. See you next time.